Well, howdy, everyone. I'm David Glazer, and I'm here with my colleagues, Katie Hilton.
Hello.
And Catherine London.
Hi, everyone.
And we are going to walk you through the 2 midnight rule, the physician fee schedule, and then some other new stuff for 2014. Just a few quick announcements. So first, the next webinar, you're going to want to put this on your calendar. I know I'm going to be listening to this. January 8th. Our topic is going to be direct pay, direct pay contracting. So clinics entering into contracts directly with either patients or with their employers to provide services. This is a new thing that's going on, and so Jim Platt, Lori Hartman, and Catherine London are going to talk about that. They've been doing some really interesting, novel stuff. I would go with cutting edge if it wasn't overused. So I will be listening to that on January 8th and hope you are too. So in our new full screen mode, if you want to see the chat box, and I would encourage you to be able to do that, like if you want to ask us a question, hover over at the top, move your mouse up to the top middle part of the screen, hover, and you will see a place you can click to open the chat window. That's where you can see messages that come out from Robert. He's going to be sending a few out today, and it's where you can ask us questions. So remember now, we don't send out discs of the talks anymore. Instead, all of our slides are available on SlideShare. And Robert will send out to you right now a link in the chat box, which you can get to by hovering over the top middle, of all of our past webinars that are on SlideShare. You can listen to them for free. This one will be posted there in about a week. And that's where you find our old webinars. Finally, I don't know where you are, about what the climate where you are, but right now it is freezing here. And everyone knows that when things get cold, they slow down, including the internet. So if the internet slows down in the middle of our talk and our sound breaks up, you can dial in. Robert will put that number in the right side. By the way, if you decide you wanted to open one of the things Robert sends you, I would advise right-clicking on the links and click open in a new window, and you shouldn't lose our webinar as we go on. Okay, so our agenda for today, and this is the order in which we're going to cover things. Some things will be covered more quickly than others, but if there's something in here you're going, God, I don't want to hear about that again, you can see what we're going to talk about and go through it. We're starting off with the 2 midnight rule, which is obviously a big deal. It took effect October 1st. We're going to go into some detail here. If you're an addict to the 2 midnight rule, don't forget, Katie and I did a webinar in August. If you look at the SlideShare listings, that's the whole thing is there. So this is the first time that Medicare admission status is covered in a rule. And one of the things that strikes me, I hear people who talk about how confusing this rule is. I am in a different camp. Frequent listeners know I make fun of CMS rules all the time. I am a scoffer. I guess I'm a scofflaw. And this time I'm not making fun of this rule. I think this rule is actually clear. I think it's explainable. We're going to try to do it in relatively short order. I think you can do it in just a few sentences. I think this is an improvement other than the fact it's going to lower reimbursement. I think it's going to let you reallocate resources away from admission reviews, and I will put in a plug right now. I am a fan of using the term review and not audit, and that's for reasons that Robert will push out if you want to watch the documentation deficiencies aren't overpayments webinar, Robert will push that one out to you. So use the word review, please, and not audit. And now Katie's going to walk us through the statute, and then we'll go through some of the guidance that's come, or not the statute, sorry, the regulation.
Okay, so first things first, there's actually a rule on this, whereas in the past it was just manual guidance. So we actually have a regulation that's enforceable, that's somewhat helpful, and that we can look at. So I'm just going to walk you through it pretty quickly. The first half of it is really about what you need, which is an order, and then the second part is more important for our kind of discussion purposes. It talks about what the order has to be based on. So subdivision A says that in order to get paid under Medicare Part A, you need to be an individual that is considered an inpatient. So now, who's an inpatient? Inpatient, if you're formally admitted as an inpatient pursuant to an order for inpatient admission by a physician or other qualified practitioner. Okay, so you have to have an order, and that's in the rule now. The order, skipping down to the blue language, has to be present in the medical record. It has to be somewhere, and it has to be supported by the admission progress notes. So this is, David will comment on this later, but this is one of the first times we see the argument that documentation has to be present in order to get paid. This is now becoming a reality in this context.
And I think Katie's point is an important one. So if you go watch the documentation webinar, like this post dates that, and you need an asterisk. There are a few times where Medicare explicitly requires documentation. Here's one.
All right. So the second section here talks about who can furnish the order. And it's basically any qualified licensed practitioner who has admitting privileges and who's knowledgeable about the patient's hospital course, medical plan of care, and current condition. Okay, so this is actually an expansion of what was originally proposed. They were going to say it has to be the attending physician or sort of the physician of record who makes this order, and they've expanded it to say it can be another practitioner who's knowledgeable about the patient. So this is actually sort of a good thing for people.
But
More
what
flexible.
about a nurse practitioner? Can a nurse practitioner do it? And the answer to that is if they're authorized to admit patients to the hospital. And so that becomes kind of the key thing is bylaws are going to matter here. It's got to be someone who can admit patients both under state law and under the hospital's bylaws to the hospital.
Okay, so the next part basically just says the physician order is a required component of the physician certification of medical necessity of the services. This is basically, so as most of you probably know, there should be a certification on file from a physician, from each physician who's admitting to the hospital that says that they're certifying that the services they order are medically necessary. So this is just saying that that order goes along with those lines. You have to say it's medically necessary. That's the basis of the order. And then the order also has to be furnished either at or before the time that the patient is admitted as an inpatient. And we'll talk a little bit more about that in a moment. All right, this is kind of the, this is where the meat of this is. So this is about this is about how you determine whether someone should be admitted as an inpatient, how you make your order. So the text says, first, there's an exception to this rule we're going to talk about. We'll get to that in a minute.
This is about as poorly written. So this is the part that you could make fun of. This is written like crap.
It's kind of written like a bad manual section,
Yeah,
but we'll work through it. So the first section says that, except as we'll talk about in a minute, when a patient enters a hospital for a surgical procedure that's not an inpatient only, that's not on the inpatient only list, a diagnostic test, or any other treatment, and the physician expects to keep the patient in the hospital for only a limited period of time that does not cross 2 midnights, then the services are generally inappropriate for inpatient admission and payment under Part A. So this is like the key thing. This is about the expectation at the time of admission. If the expectation is that the patient will not cross 2 midnights, then Medicare is probably not going to pay, with some exceptions.
And God knows why they made this a double negative. I don't know. But there's an easy way to say this, which is what's coming up next.
All right. So surgeries, diagnostic tests, and other treatments are generally appropriate for payment for inpatient admission and hospital payment under Part A when the physician expects the patient to require a stay that crosses 2 midnights. So if you expect the patient to be in the hospital for more than 2 midnights, crossing 2 midnights, then you will get paid by Medicare.
And that's the easy way to put it.
That's the easy way to put it.
Avoid the double negative. Someone's going to be in for 2 midnights. They're properly, you expect them to be in for 2 midnights. They're properly an inpatient.
Okay, so that's a good, clear standard. There's a little more that you have to know. The expectation is going to be based on a number of different things, factors, patient history, comorbidities, severity of signs and symptoms, current medical needs, and risks of adverse events. Okay, so it has to be based on these items. But very importantly, the factors that led the admitting practitioner or physician to that decision to admit, that decision that the person was going to be there for more than 2 midnights, those have to be documented in the medical record in order to be granted consideration. It's a funny little phrase, but basically, if you want to get paid, document why you think they're going to be there for more than 2 midnights. Okay, so this is the weirdo exception paragraph that I think actually is just superfluous. So this is when those general rules you talked about, expectation, don't apply. So if there's an unforeseen circumstance, such as a death, transfer, shorter stay than your expectation, then they would not be, basically, it's not appropriate to admit them, or they wouldn't be paid.
They're still inpatients.
They're still inpatients, right. If there's an unforeseen circumstance, which that wouldn't be your expectation, it was unforeseen, then they would still be paid. So basically, I think you kind of ignore this little section, because basically you're still talking about having an expectation of crossing 2 midnights, and if that's there and it's documented, then you get paid.
And so here is, in a nutshell, the bottom line. It's all summed up by expectations control, okay? What you expect to happen when you make the admission decision controls. If you think they're going to be in 2 nights, you're good to go. Now, how do I know this? Well, here's a CMS Q&A, and I was going to include a link in the stuff. The CMS website was totally frozen on Monday as we were finalizing the slides. So the link to the Q&A isn't in here, but it's pretty easy to find, and here's the text. Will Medicare contractors base their review of a physician's expectations on medically necessary care that surpasses 2 midnights upon information available to the admitting practitioner at the time of admission? Answer: yes. CMS's long-standing guidance has been that Medicare review contractors should evaluate the physician's expectation based on the information available to the admitting practitioner at the time of the inpatient admission. Now, I don't know if I could make this any more colorful. This remains unchanged, and CMS will provide clear guidance on training to our contractors at the medical review. Now, this is a huge deal. For a number of years now, Katie and I have been telling anyone who will listen that admission determinations are not supposed to be done retrospectively, looking at what happened over the course of a hospital stay. We have said over and over again, you don't have to look at the severity of illness and intensity of service, the SI and IS, as they are conventionally referred to in interqual. That isn't an expectation for Medicare. And a lot of people have said we're nuts. This Q&A is extremely explicit that today and in the past, the physician's expectation at the time of admission controls.
And it's totally important because many of you are still appealing things in the past, and there are a number of dollars out on the table where CMS has denied coverage where just because something happened in the course of the stay that they think that the inpatient admission wasn't proper. So this is another urging you to continue to appeal that because you have even better language here supporting that what you did in the past was correct.
Now, a couple things about that very point. So Catherine and Katie are doing more of these appeals than I can shake a stick at. And so this physician expectation thing, there's one Q&A I didn't include because I did not know what Catherine London is about to point out. So CMS has said that you don't have to document an expectation in the medical record. You don't need to write the words, I anticipate the patient being in for 2 midnights. What you must document are the factors. That's what's in the regulation. It's what's in the Q&A. Document the factors. Now, Catherine, have you seen anything recently in any appeals decisions that people should know about?
So in a lot of the recent appeals, we're seeing CMS applying this new expectation of the physician at the time of admission, and they are stating that this is, in fact, the standard that does apply. And this is new language that we haven't been seeing. In the past, they've been sort of basing the decisions on what happened during the patient's stay in the hospital. And so now, since September to October, I'm seeing a lot of language in the appeals that are stating that the decision has to be based on the physician's expectation at the time of admission and whether the physician expected the patient to be in the hospital for 24 hours or more.
And that part is good. I mean, the fact that they're doing it on the expectation is purely a good. But there's a hint that they're looking for something they shouldn't be looking for, which is the affirmative statement, I expected the patient to be in more than 24 hours, which is something I've been a fan of doing, but I don't think was a requirement. Which brings us to the next point here. CMS explicitly says that they don't anticipate having a physician attestation about length of stay. But I'm a fan of using one. I've been a fan of using one for a while. I thought for a while that if you just say, I expect the patient... Let's try this again. I expect the patient to be in overnight. I think you're bulletproof. Now, the Q&A has another really interesting thing. It says that the physician should use age, disease processes, comorbidities, and potential impact of sending the patient home as factors for determining the necessity of a stay. The reason I've underlined the potential impact of sending a patient home is for some time there has been the conventional wisdom that what are often called social admissions aren't appropriate. That you've got the 95-year-old grandma in a rural area, you can't keep her overnight. And so, Katie, you were going to say something here.
Well, and it's funny because even in the Q&A transcript from this call where this came from, they say at different parts that social admissions are not payable by Medicare. So they're making this distinction between what they think is a general social admission, but also this factor here that is apparently important for this calculation of expectation.
So here's the David Glazer opinion on this, and it's not based yet on extensive research, but this is what I think it means. To me, a social admission is grandma can't get a ride home. If grandma can't get a ride home, you can't keep her. And that makes sense to me. And I think that is different from grandma lives alone, can't manage her meds, and if she goes home in the altered mental state that she's in without someone to care for her, something bad's going to happen. I think that's different from can't get a ride home.
And if I think I was using that factor, I would be saying the medical reasons and being pretty clear in my documentation as to why she's not going to be safe at home.
So what we know is that this Q&A, which is not the same as a regulation, but is put out by CMS to answer questions about the regulation, says that you can consider the potential impact of sending the patient home, and gosh darn it, I'm going to do so. CMS has said, now this is a thing to keep in mind. Some people think, back to this intensity of service, if the person needs a lot of care, that justifies an inpatient admission. That is not contained in the new rule. And so CMS has said ICU admission by itself doesn't justify admission. If you're admitting someone to the ICU and don't think it will be for 2 midnights, they don't think that justifies admission. Now, I'm hard-pressed to think of scenarios, but I suppose if you thought someone had a life expectancy of 12 hours, that would be an interesting one. And I don't think that's been flushed out yet as to what happens there. But arguably, you don't have an expectation. And we've beat this into the ground, but remember, this is a place where documentation is required explicitly in the regulation. So when do you start counting time? And I always think of the counting crows here. But okay.
It's dating you. It's dating you, David.
No one else will date me. All right. So counting time. So the guidance talks about the time the patient, quote, starts receiving services, unquote. It then says explicitly that it excludes time in the waiting room. And so the actual language is it excludes time prior to the initiation of care. Then it says, therefore, triaging activities, such as vital signs before the initiation of medically necessary services, responsive, and there should be a closed parentheses there, responsive to the patient's clinical presentation. Now, this is interesting because in my small brain, a triaging activity feels like a service, And so I think if you're triaging, that I would have called that receiving services. But I think they're trying to draw a distinction between something that you do and then throw the person back into the waiting room and something else. So I don't know. So
if you go back to a room after you've been triaged, then you're probably starting to get medically necessary services, but you're just back with the rest of the crowd.
What if you're waiting in the room and just reading your book that we recommended during the sound checks?
It's a fair question.
I don't know. So, okay. Outpatient time counts for determining the time you spend in the hospital, but doesn't count as inpatient time. And I realize this can sound confusing, but here's what we mean. Someone comes in as an inpatient. They walk in as let's try that again. Someone comes in as an outpatient. They walk in at noon. They spend the night, so they're there 1 midnight. And the next day you say, they're going to be here overnight tonight. You count that first midnight for the 2 midnight rule. If you know they're going to be there 1 more, you now have 2 midnights and you admit them. But the admission day is the second day. They're only in the hospital for 1 night. And hopefully that made sense. I don't think that's too confusing. But so you've got 2 nights in the hospital, but it'll be a 1-day stay.
So is the first day paid as an inpatient, David?
And so because this is what's really cool, because of the way DRGs work, you're admitted. And although there was hint, and we talked about this at some length in August, it sure sounds like CMS is saying you get to bill an outpatient service for that first thing. And it even kind of sounds like it didn't bundle under the 72-hour rule. I don't know. This is an interesting thing that I haven't heard much more about since we talked about it. Okay, we're spending a lot of time on this kind of intentionally, but don't worry, we are going to get to the fee schedule. So I just want to spend a quick minute on interqual and Milliman. And one of the things I like about this slide format, if you look at interqual, I believe that is the male gender sign there in interqual rather than a Q. I don't know. So do you use interqual and Milliman? So let's see what CMS says about this. Does the beneficiary stay need to meet inpatient utilization review screening criteria? Well, if the physician expects the beneficiary's medically necessary treatment to span less than 2 midnights, you treat them as an outpatient. If they're unable to determine whether they'll be 2 midnights, you put them in observation. And here's the key thing. While UR committees may continue to use commercial screening tools to help evaluate patient admission decisions, the tools are not binding on the hospital, CMS, or its review contractors. In reviewing stays lasting less than 2 midnights after a formal inpatient admission, i.e. those that don't get the presumption of medical necessity, we'll come to that in a minute, contractors will assess the reasonableness of the physician's expectation of the need for and duration of care based on complex medical factors like history, comorbidities, and so on, which must be clearly documented. So in plain English, for Medicare, there's not really a reason to use interqual and Milliman. The real test is, what does the doctor expect? Okay? And once again, we've been saying this for a long time, and we've gotten a lot of argument. I think it's pretty clear at this point. So, Katie, what happens if someone is in less than 2, actually, and I keep saying less, it should be fewer than 2 midnights.
So, a lot of people are saying, does that mean we're automatically not going to get paid? No, that is not the case. CMS has very helpfully said that, again, this is based on the physician's expectation. And if that expectation was reasonable based on the factors that you're supposed to include in the medical record, then you will get paid for the inpatient stay, even if they didn't stay for the whole time they crossed the 2 midnights. And this is really just sort of a continuation of the FAQ. So you can see the language in here that is hopefully making you feel better. If you had a reasonable expectation that they would cross 2 midnights, then you're going to get paid. Make sure you have in the medical record. That's going to be really critical. There is that little caveat that CMS has said there are going to be some cases where you don't expect to stay lasting 2 midnights, but nevertheless they're appropriate as inpatient admission. So this is a little funny. We don't know exactly what's going to come of this little exception. There's been one instance already where CMS has said that these new mechanical ventilation services, they aren't yet on the inpatient only list, but they are very similar to things that are on the inpatient only list. And so for those services, you might not expect to stay crossing 2 midnight, but it's going to be appropriate for them to be inpatient admissions. So if you want more on that, just let me know. We can send you the info on that. Now, the contractor is going to be instructed to deny any claims if you're trying to meet this little exception, and then it's going to go to a higher up at the CMS office, and they're going to say, okay, is this a situation where it wasn't reasonable to expect someone to be crossing 2 midnights, but they needed inpatient care in those cases? And so we'll probably see more issuances of cases CMS thinks about this.
And this highlights a question. I had a meeting with one of my colleagues, John Lundquist, and I met with the Department of Justice for a long time on Monday. And we were talking about the ICD, the implantable cardiac defibrillator investigation. And the government's position is, well, if you've got a service that is arguably not covered, you should flag that somehow on the bill. And we said, where does it say that? And they were clearly stumped by that. I don't think it says it anywhere. And I think there's an interesting question of what you're practically supposed to do when you have a situation that you're seeking payment, but you're not sure if it should be covered. There's a comment field you could potentially use. I don't believe there's any instruction that I know of from the government, and we asked the government multiple times in that meeting to point the instruction, and they couldn't. If you want to be able to have CMS review it, you got to bill it. Right. Okay, audits, we're not going to spend long on this at all, but just FYI, they're doing prepayment reviews, probe reviews, up until the end of March of next year. They're going to do 10 bills for most hospitals, 25 for large hospitals. I have no idea what a large hospital is because they didn't choose to tell us. I'm assuming a critical access hospital is not large, but anything beyond that, I have no idea. If there are no issues, then they're not going to do any further reviews unless there's a significant change in your billing pattern. If you have moderate to significant or major concerns, I just loved that, then they'll do more reviews. After 6 months, the sample size is going to go up to 100 charts for small hospitals and 250 for large.
And there is an instruction that the RACs are not supposed to be looking at admissions between, well, right now until the end of this year. Yep. And so if you get a RAC looking at admissions and denying you on these new rules, you should push back because they're not supposed to be.
Correct. Okay, last thing we're going to do on this. Language can be confusing, and the terms benchmark and presumptions get tossed around, and I think that makes things unnecessarily complicated. The benchmark is just the idea that the doctor needs to expect a 2-midnight stay. That's the benchmark. The presumption is that if the patient is in for 2 nights, we presume the stay is appropriate, and it's a rebuttable presumption, meaning if there was some evidence to show that it wasn't medically necessary for the person to be in the hospital for 2 nights, and this is an important and, the doctor shouldn't have expected them to be in for 2 nights, then the admission could be denied. So remember, it isn't just that they weren't in for 2 nights or that they shouldn't have been in for 2 nights. It has to be that you shouldn't have expected them to be in for 2 nights. So hopefully we've made this pretty clear. I don't think it's that hard. And if you look at the big picture, there's one giant negative here. The number of admissions goes down because in the old days, we were told you could admit someone if they were going to stay overnight or 24 hours. And we won't belabor this. There's actually 3 standards. They're inconsistent. It was crummy. You can watch our other webinar for that.
Keep appealing them.
Yeah, keep appealing them. Katie and Catherine are winning these things just right and left. These are winners. So appeal them. And we can help on that if you want. It's cheap. We've kind of got a machine going. In every other respect, this is clear and articulable, and it should save on your reviews and on your training. Okay, now, on to the hardest talk we give every year on the physician fee schedule. It's hard because there are things in here that are really important to some of you, or almost everything in here is there's important to some of you, but not all. And so it's always hard for us to decide how much detail to go into. So bear with us here. This is where specialty societies earn their pay. I'm going to start with the general stuff because I'm not smart enough to get into the details. So I'm going to just look at a couple of big picture things, and Katie and Catherine will walk us through some more stuff. So, and remember, this thing was 1,369 pages, and even though they're double-spaced, we're not going to be able to cover that 1,369 pages in a half an hour, but we'll try to hit some highlights. So one interesting discussion is about misvalued codes, and there's a discussion of some misvalued codes, and I'll have a list of the ones that they talk about, but there's one sentence that really resonated with me. While talking about Mohs procedures, and as you may know, that's removing potentially cancerous skin lesions. It's a procedure done in the derm world a lot. There was a statement that code 17311 and 17313 were proposed as potentially misvalued codes because we believe that these codes may be overvalued based on carrier medical director comments suggesting excessive utilization. And I read that and went, whoa, we think there are too many Mohs procedures which suggests that we pay too much for them? That doesn't really make sense. But it says something about how CMS is looking at stuff. And Steve Beck, one of our colleagues, has often said, geez, if I'm CMS and I want to cut on a procedure, one of the ways I do it, I just lower the reimbursement for it. And that's kind of what, in essence, they're saying here, we think you're doing too much of it, so we're just going to pay you less for each one. Weird way to handle it. Here's a list of the potentially misvalued codes. It's in your materials, so I'm just moving on. Another thing that caught my eye is something that isn't going to happen, but I'm mentioning it because the discussion was interesting. There was a lot of thought about, a couple of things. So first, this is something that did happen. So they lowered the codes in a number of situations where payment in the office exceeded payment in a facility. And I think I failed to include the list of that. I meant to do that here, but there's a list in the fee schedule where they do that. And so they're worried about, they want facility payment to be higher than office payment. So the second thing is the thing they didn't do. They were considering changes to the geographic practice cost index. And that's one of the things that goes into how your RVU calculation and how you get paid for office visits. And there was a potential change that would shift reimbursement from decrease it in rural areas and increase it in urban areas. So like right now, the geographic factors are really strange. Wisconsin is an area, Greater St. Louis is an area, and Manhattan is an area. So they'd say sometimes it's a state, sometimes it's a metropolitan area, sometimes it's a portion of a metropolitan area. They talked about doing this shift that would shift money away from rural and into urban areas. They're not doing it, but the takeaway message for me on this is CMS is really thinking a lot about reimbursement, and there is going to be a lot of fight coming up about a shrinking pie. And this is where, once again, specialty societies and stuff are really going to earn their pay. And so here is a slide. This is just, I stuck it up. You can look at it at your leisure. This is how CMS thinks practice expenses fall out. So those of you who are number gurus, you might just find this interesting. It's kind of a percentage of how they see expenses. All right, very quickly, I'm going to mention a couple of substantive things in the rule. Incident 2, There's now a requirement that services that are billed incident to must be provided in accordance with state law. I don't think this is a really big change. They're saying it's a condition of payment. I don't know where they're getting that, because there's nothing that says incident to is a condition of payment in there. But it is worth noting the definition of auxiliary personnel, and I just toss it in here because sometimes people wonder, can you lease an auxiliary person? Like, can you lease a nurse practitioner from your hospital? And the answer is clearly yes. It's been clearly yes, but it's really clear here. You can have an independent contractor who's your leased employee. But the takeaway message is your incident to person, they don't have to be an employee, but they have to meet whatever licensing requirement state law had. I frankly, if you'd asked me that before, I would have said I thought it was true. Last thing I'm going to talk about is PRRB, and I'm not going to spend long on this. There's some stuff in the outpatient rule that changes PRRB things. I'm not even going to go into that. It's too nuanced, and a lot of you probably don't care. I do want to mention there are new changes to the rules that came out last year in March, and so if you do PRRB stuff, please pay attention to that stuff. They changed things related to group appeals and CHIRPs, which are common interest related party appeals. The electronic waitlist, everyone's going chirp, chirp here now. An important thing to keep in mind, and you want to whitelist the government, and you want to whitelist your carriers, your MACs, and your RACs, because stuff is coming out on email, and I don't know if this ever happens to you, but it goes into your spam filter. And the PRRB specifically called attention to, we're sending our communications out electronically. If you don't get them, tough. And I just want to also mention, so this stuff is in there for those of you who do PRRB stuff. I have done fewer PRRB cases as of late, and I just saw some statistics that explain that. Here, the number of cases in over 10 years went from 14,000 to 600 of new cases. And also just mentioned, this is the batting average last year. There were 6 wins at the PRRB, 4 of which were reversed by the administrator, and 16 losses. So the batting average at the PRRB is way worse than it used to be, where it felt like you won most of them. And then an interesting tidbit, when you do win at the PRRB in the window from 2000 to 2012, 93% of the time the administrator reversed the decision. So the lesson for that, if you're thinking about taking something up to the PRRB, and if you are, I'd certainly love to help you. But don't do it unless you're going to district, if you're willing to go to district court. If you're just taking a shot at the PRRB, the odds of you winning are low. So I am now going to turn this one over to Catherine, to Katie. I'm going to turn it over to Katie, who's going to talk about telehealth.
All right, so there's a little update on telehealth. I won't go into what it is, what telehealth is and everything, but for those of you who are doing it, this hopefully is good news to you. So currently the rule is that the originating site, which is where the patient sits and is then receiving the telehealth service, has to be in one of 3 areas. It has to either be in a rural health professional shortage area or a HPSA, a county that's not a metropolitan statistical area, or some approved demonstration project. So the conundrum that people were finding was that a rural HPSA isn't actually defined, and CMS was picking various definitions of a rural HPSA at various times and causing a lot of people confusion, and resulting in sometimes beneficiaries getting telehealth services and then that being switched sort of in the middle of their treatment. So as of January 1, there is now a definition for rural HPSA, and that is basically a HPSA that's in a rural census tract that as determined by the Office of Rural Health Policy. So what does this exactly mean? So I'm not a guru on the rural census tract, but I have learned that there are some areas in metropolitan statistical counties that are actually considered rural. So metropolitan statistical area wouldn't be rural, but there might be some exceptions to that. And they are going, and CMS is now going to say, even in those census tracts, those are now going to be, you're going to be able to do telehealth services if the originating site is in one of those census tracts. So they are expecting this to expand telehealth access. So that's really pretty good. The other thing they're changing is that there aren't going to be any changes in the middle of the year as to what's rural for telemedicine and what isn't. They're going to use the status of the area in question as of the end of the last year so that you aren't going to see any interruptions in services based on what is rural and what is not. So CMS, I went online to try to figure out how do you figure out if you're in a rural census tract. CMS there's not a really good way right now, but they're working with the Health Resources and Services Administration to develop some tools so that you can hopefully just enter your zip code or just to figure out whether you get to do the telemedicine. And so there's a link to that website now, though the tool is not there as of at least Monday.
I'm just going to chime in real quick and say we're getting some really good questions. Feel free to send your questions. Don't forget, you just hover over the middle and use the chat box. We will answer the questions at the end.
The other telehealth piece is that there are going to be 2 new CPT codes that are going to be eligible for telehealth. There are these transitional care management services, which are services that are provided when someone is basically going from a skilled or inpatient setting back to their community setting. Now you're going to be able to do a certain number of telehealth services under these codes and get paid. There was a push to remove this limitation on subsequent nursing facility services that could be done via telehealth. You can only do 1 in 30 days, and a lot of people wanted that removed, but that is still in place. CMS thinks that these people need to come back in and see the physician and not necessarily do telehealth more than once every 30 days. So that is still in place. All right, I'm going to talk briefly about this change. This is relevant for people who are defending against overpayment allegations currently, or they're thinking about they're needing to do an investigation and need to figure out how far back you go. So this is a relevant thing. This was a change that we saw with the fiscal cliff legislation back this past January, and you can listen to our webinar about that on the SlideShare site. But basically what happened with the fiscal cliff legislation is that Congress, there is this presumption in the law that you are without fault and that the government cannot recover overpayments from you if they determine the overpayment exists, and it used to be subsequent to the 3rd year following the year in which notice in which you were paid. Okay, so you got this presumption after 3 years, which is pretty good. That was changed so that you don't get the presumption until 5 years. So that effectively means that the government has a longer period to recover. And that was changed in the statute, and now it's been changed also in the rules. So I guess operationally how this works, under the 3-year presumption, say you got paid in 2010 and you didn't think you caused the overpayment, the government wouldn't have been able to recover from you until any time after 12/31/2013. Now they have until 12/31/2015 to recover. So it's kind of a bummer. There was kind of a big outcry, people saying this really creates a lot of uncertainty for us. This really isn't fair. And in response to that frustration, CMS has said, don't worry, we still have these reopening rules that bind us. And so that basically says CMS can't open a claim for good cause after 4 years. And so in a way, they're using these reopening rules to sort of say, it's okay, we're actually limited by this 4-year standard. So that is a good indication that the reopening rules might be the rules that limit your going back.
And just, I want to make one important clarification here, which is years is used differently in these two things. So the limiting on reopening is 4 years, as in 48 months, the way you would think of a 4-year period. Whereas the other one is years after, think of it in whole calendar years. I'm not going to, it's not worth going into that in detail because it doesn't matter. The bottom line from a practical level here is you just keep using 48 months.
Right.
If I could just chime in, if you are interested in learning more about what David was just mentioning, we did go into this in depth during our Fiscal Cliff webinar last January. So feel free to check that out on SlideShare, and there's a really good discussion in that webinar.
All right, so the PQRS in the fee schedule went on for about 400 pages, so I'm not going to bore you with it. I'm just going to kind of give you a broad overview. For the 2014 incentive, for those of you who are doing this, there's been an increase in what you have to do. So instead of doing 3 measures, reporting on 3 measures, now you have to report on 9 measures, and then you also have to report on more national quality strategy domains. So there's an increase, despite resistance, on what you have to do to get that 0.5% 2014 incentive. There is a little bit of help here in that you only have to report on 50% of patients rather than 80, but just putting that out there, and if you want to get into details, we can totally do that, and just give me a call. Now, the 2016 payment adjustment, which is the 2% of the fee schedule amount, that's not going to be an adjustment until 2016, but the reporting period is the same as it is for the 2014 incentive. So I won't go through them in detail, but here's what you have to do generally to avoid the 2016 payment adjustment. This is what you have to do in 2014 to avoid an adjustment in 2 years. This is the confusing thing. So you have to report on at least 3 measures for at least 50% of the eligible professionals Part B patients. and cover one NQS domain, or you can otherwise meet the 2014 incentive in some way, and you're going to avoid that 2016 payment adjustment. There's a new reporting option, a qualified clinical data registry. There's going to be a process by how you get those qualified. Again, if you want to know more about that, let me know. And all the changes here are really driven by CMS trying to align payment incentives, EHR, meaningful use, PQRS, all into sort of one reporting criteria.
We are considering whether to do a PQRS. We may do a
Yeah.
webinar on this topic, so if you think that would be a worthwhile thing, put it in your comments.
Let us know
We're-
for
we're-
sure.
We're sort of toying with that.
Yep, and the PQRS actually ties into what I'm going to talk about now, and that's the value-based payment modifier. But if I could just take a moment first to thank CMS for waiting until late on November 27th to release the 1,369 pages of the final rule, because that gave Katie and David and I some really interesting Thanksgiving weekend
Discussion
reading.
topics, yes.
Yes, we were very pleased. So, as a quick background, the Affordable Care Act requires CMS to adjust payments to physicians under the fee schedule based on quality and cost of care they provide. And by law, this adjustment will have to go into effect for all physicians and groups by 2017. But CMS will be phasing this adjustment in to apply only to certain groups starting over the next few years. And specifically in 2015, this adjustment is going to apply to groups with 100 or more eligible professionals. And in the final rule, CMS confirmed that it's going to apply this payment adjustment to groups with only 10 or more eligible professionals beginning in 2016. So groups are actually categorized based on their participation in the PQRS, and groups that are not reporting under the PQRS, either as a group or with 50% of the individual professionals meeting criteria for individual reporting, they will be subject to an automatic 2% penalty. And I should note that this is in addition to the 2% penalty that Katie just discussed under the PQRS reporting. So some groups could see potentially a 4% penalty starting in 2016. In terms of how this adjustment will work, CMS is going to create a standardized score for quality measures reported through the PQRS and also certain cost measures that it's established. And each physician group will be rated based on quality and cost and classified as either high, average, or low performing. And this will result in an upward, downward, or neutral payment adjustment based on the group's performance. So for groups that have fewer than 100 eligible professionals, they'll be subject only to upward or neutral payment adjustments, whereas with groups of more than 100 eligible professionals, they could see the penalty that I just mentioned. So CMS has also indicated that it's going to increase the payment at risk to 2% beginning in 2016. And you can see in this table how the adjustment will apply to groups depending on their performance rating. And you can also note that some groups could be eligible for an additional payment incentive if they provide care to certain high-risk beneficiaries. In terms of what kind of effect this could have, CMS released some information based on 2012 data that suggests about at least 1 out of every 10 physician groups could see a payment adjustment in 2016. And also note that there is a significant gap between the performance period and payment period. So for 2015 performance period, the groups will see payment adjustments in 2017. And we already mentioned how this is part of CMS's overall kind of intent to align some of the PQRS quality measures with other incentive programs. So I'm going to move on to talk about a new payment that's going to be available in 2015 to physicians who provide care or who manage care to patients with chronic conditions. And this will result in reimbursement for non-face-to-face services that are provided to patients with 2 or more chronic conditions who meet these requirements that are set forth on this slide. And as I mentioned, payment is expected to begin in 2015, and CMS will be developing standards during the next year and seeking input on these standards. So I won't go into some of the practice requirements in depth that are required for obtaining this reimbursement, but basically they focus on the practice being able to provide around-the-clock care to these patients, and it's consistent with what's generally required for a primary care medical home. I should also note that one of the requirements is the opportunity to communicate with providers 24 hours a day through any form of asynchronous, non-face-to-face consultation method. There's also a written informed consent requirement that CMS discussed in the final rule, which I won't go into in depth here, but just note that providers must obtain informed consent before billing for the chronic care services. In 2015, there's going to be a new G-code to bill for these services, and it requires the practitioners to provide at least 20 minutes or more of chronic care management to patients during a 30-day period. Now, this code can't be billed by more than one practitioner during the same 30-day period, and also cannot be billed with the following codes that are listed on this slide during that same time frame. So note that specialists and other non-physician practitioners are also eligible to bill for this code. The last thing I'm going to touch on this issue is incident to billing in this context, because in this final rule, CMS confirmed that the members of the care team who provide services to patients after hours are able to bill, or are able to that time does count and can be billed incident to if certain requirements are met. And as you can see on the slide here, CMS confirmed that direct supervision, which is usually required in the incident to context, is not required to bill for chronic care management, because only general supervision would be required so long as they meet these requirements. But it's important to note that the staff member must be directly employed by the physician or practice, which differs from what David just told you in the general incident to billing context.
At least they kept it simple. And hey, I just want to apologize. I know we're having a little bit of a sound issue. Our phone died, unfortunately, right before we went on, so we're in a backup. So hopefully we'll try to be really clear here, but bear with us.
So I'm moving on to another new change that CMS announced in the final rule, and that's it had finalized the proposal to apply therapy caps to critical access hospitals beginning in 2014. And just as a quick background, Medicare currently imposes an annual cap on outpatient therapy services that are provided to beneficiaries. And there's one cap for OT and another separate combined cap for PT and speech-language pathology services. And you can see the cap amount that they've set for 2014 here. And there's also an exceptions process in place for any services that are medically necessary that are provided in excess of the cap amount. But it's important to note that unless there's legislation passed in the next few weeks, this exceptions process is set to expire at the end of 2013, which means providers will no longer be able to submit claims with a modifier to request an exception to the therapy caps. So historically, the caps applied to all outpatient therapy services that were provided by a hospital, and CMS consistently interpreted this exemption to extend to critical access hospitals, and it even expressly established regulations that expressly excluded caps from critical access hospitals from the therapeutic caps. This exemption was actually suspended in 2012. And with the fiscal cliff legislation, the American Taxpayer Relief Act in 2012, CMS also extended this suspension through the end of 2013, which meant that the caps applied to all outpatient hospital services through 2013, and it also mandated that therapy services provided by critical access hospitals count towards the cap during that time. Now, it's important that Congress did not suggest that critical access hospitals should be subject to the caps after 2013. This was intended only to be a temporary change. However, as a result of this change, CMS actually reassessed its interpretation of the therapy cap statute and determined that critical access hospitals were not excluded from the therapy caps based on the language of the statute. So what does this mean? This basically means that beginning on January 1st, the services that are provided by critical access hospitals, the outpatient therapy services, will count towards the caps. And so if beneficiaries are receiving therapy services at critical access hospitals, this will count towards the cap amount, and there could potentially be no exceptions process in place, since, as I mentioned, that is set to expire at the end of this year. So this is a big change in CMS policy, and this could impose some significant limits on the therapy services that are provided to beneficiaries.
All right, this is Katie Yelton again. Excuse me, and I'm just going to highlight a substantive item or two in the outpatient prospective payment system, which also came out late on Thanksgiving Eve. So many of you have been on the road with us since 2009 as we went through CMS's tortured attempt to clarify its supervision requirements for both outpatient diagnostic and therapeutic services. So basically, back in 2010, CMS said that for outpatient therapeutic services, which are not diagnostic, basically anything that's not a physician service and that's not diagnostic, so a good example is observation services, those services have to be furnished under the direct supervision of a physician or non-physician practitioner. That non-physician practitioner has to be privileged appropriately and also acting within their state scope of practice. And direct supervision means that supervising person has to be immediately available to furnish assistance and direction throughout the performance of the procedure. They don't have to be in the room, but they have to be able to get in there and help if something goes wrong. So, understandably, everyone was upset about this, but particularly critical access hospitals where practitioners are just not abundant for this sort of thing. And so CMS said, look, we're not going to enforce it for a while, and that kept getting extended. But that is over. That notice of that non-enforcement instruction is over as of January 1. So as of January 1, critical access hospitals have to comply with this. It's just hard because there's just not a lot of people available to help do this. So what in the world do you do? Well, it doesn't have to be a physician who's supervising. It can be a non-physician practitioner. So there's a little bit of flexibility there, so long as they're meeting state law and they have privileges. Note that pulmonary rehab, cardiac rehab, and those sorts of programs have to be physicians, so that's an exception. And you can also try to talk to CMS about changing the required supervision level for certain procedures if you want to lobby that way. There are a certain set of services that are non-surgical extended duration therapeutic services, which basically means therapeutic services that last a long time that aren't surgery. And CMS has said, look, we only require direct supervision, that immediately available thing, at the initiation of the service. And once the supervising practitioner thinks they're stable, then it's general. You don't have to be immediately available. All right. And so there are a list of those services. I've included the link on this slide. And there's a clarification in the outpatient rule this year that said, look, observation services, which are billed by the hour, so each unit, there's a question, do you have to be there at the beginning of each hour and then make sure they're stable? No. For observation services, it's the beginning of the services you're provided. You need that direct supervision, and then once they're stable, the general supervision lasts throughout the hours.
Katie, quick clarification question here. Someone is asking, does this apply in an outpatient clinic setting?
And this would apply to any services that are paid for under the outpatient, the APC model. So, no, that would not be the case.
Basically, outpatient, people conventionally use outpatient to refer to things that happen in the clinic, but it's important to recognize that for Medicare, outpatient is actually really a term exclusively for hospital use. So this is a hospital requirement, not a clinic requirement, unless it is a outpatient, as a clinic based in a hospital.
Right. All right, and then the other little substantive law thing that changed in the outpatient rule was similar to what David talked about on the Incident 2 side in the clinic. Now on the Incident 2, when you're providing services, Incident 2 therapeutic services, anyone who's providing those services must be doing them in accordance with state law. So if there's some weird state law rule about a certain tech has to have a certain certification, you have to have that now, and that's clear. And strangely, in the outpatient rule context, they actually made the rule say this is a condition of payment, whereas as David pointed out, they didn't do that on the clinic side. So that's something to think about. This is, I guess, maybe a little higher risk, interestingly. All right, so we've covered a lot, and we have a few questions.
So we'll kind of do this one in reverse order. So, Katie, what is a therapeutic service? Kind of what makes a service therapeutic?
All right, so a therapeutic, therapeutic, it's sort of like it's not a diagnostic service.
I think that's the
and it's not a
easiest way,
physician
yeah.
service.
Yeah.
So all that stuff you provide, chemotherapy, chemotherapy administration, observation, those sorts of things, therapeutic.
I kind of like the not diagnostic way of looking
Yeah.
at it. Okay, this will be another Katie one. You mentioned that RACs should not be looking at claims for the 2 midnight rule prior to a specific date. Did I get that right? And could you mention the date?
Yes, good question. You did get it right. So in the open call that CMS had on inpatient 2 midnight rule, they said that RACs have been instructed not to look at inpatient stays between October 1 of 2013 and 12/31, so in a few days from now. I don't think that has been, it might have been
I
expanded.
think they extended that to March 31st.
To March 31st. And so the RACs should not be looking at, shouldn't be looking at those issues, and you should push back on that, and I can send you that language if you need it.
They will be doing these prospective reviews that we talked about. That's what's supposed to happen in that window instead. So this is a great question, and I have to apologize when we don't cover this square on. So is this for Medicare only or for all payers? If for all payers, don't we follow the 2 midnight rule? Wouldn't it be considered outpatient? And so this is, I am often guilty of talking about the rules, and generally, if we as health lawyers don't say otherwise, we're talking about Medicare, which means we're not even necessarily talking about Medicaid. So the whole 2 midnight thing was only Medicare. Remember, Medicaid, state law, totally different. Some states are going to follow Medicare, most don't. Private payers, catch as catch can. And many people, this actually becomes a compliance challenge. Many people think, well, you can't treat people differently. Not only can you treat people differently, and this is another situation where you have to treat people differently, because you might have a Blue Cross Blue Shield contract that sets out very specific criteria for what makes someone an inpatient. And when it comes to Blue Cross Blue Shield, you got to follow those. And then with Medicare, you got to follow the 2 midnight rule. Should doctors write in the pre-op if they expect the patient to stay 2 midnights and the medical reasons why? If they document this and the patient stays 1 night, would it be billed as an inpatient since they're expected to be an inpatient? And I guess the short answer to that is it doesn't hurt. I think it's helpful to write in the pre-op that you expect them and why. And I think merely writing that you expect it isn't that useful. You kind of have to include the why. Then, if they don't, that person could be properly included as an inpatient. Now, one of the themes through the CMS stuff is they're suspicious of if you had lots of people who don't stay as long as expected, they're going to be suspicious of that. But expectation controls. So, Katie, I don't know if you want to do this one or I will, whatever. At the beginning, you said a nurse practitioner could do the admission certification if the bylaws are allowed at the hospital. Would the same be true of physician assistants? What about a clinical nurse specialist? If they're allowed by the bylaws to admit, can they do the certification and have it co-signed by the physician before billing?
So I think there are 2 things you have to look at when you're looking at whether any practitioner can do the order. You have to have your bylaws that say that the person has admitting privileges. And then also whatever your state law says. We have people from a lot of different states. So if you want to look at a specific state law, let us know. But it will be largely dependent on what the state law requires.
Yeah, Medicare will allow it. It's just
they defer to state law.
And don't forget bylaws, because I think that bylaws, as Katie's pointing out, that's a big deal. And that actually goes back to the thing Katie was talking about too for supervising diagnostic stuff. Yeah, you always have to pay attention to the bylaws. Well, we're at our 1 hour here. So I will, I guess, close by saying, remember, January 8th, the coolest webinar ever about direct contracting. I think people are looking at me like they think that this was the coolest one ever.
Maybe I'm just concerned about David talking us up a little bit too much here.
But on direct contracting with patients and employers and mechanisms for doing that. And I'm talking it up because I'm really excited about it. Please don't forget to fill out your evaluations. We apologize for the odd sound quality here. Next time we will have our phone system not crash right before. And happy last webinar of 2000.